Hey everyone, it's Denise Brown from the Caregiving Years Training Academy. Thank you so much for joining us for our third in a three-part series on caregiving reflections during the pandemic. Today, we're going to think about what we looked at over the past two sessions, what the problems were that we really kind of talked about, and then we're going to focus on solutions, whatever we can think of that might help. So I'm so thrilled to welcome back some of our panelists from the first two sessions, Sharon, who cares for her husband and who helped her son through a battle with cancer. Hi, Sharon, thanks for being here. And Mark rejoins us as well, and he cares for his son. Hi, Mark. And Cameron's here as well. She cared for her mom until her mom's death in January of 2001. Hi, Cameron.
Hi.
We have some attendees with us as well, so feel free to jump into the chat room, introduce yourself, as well as anytime you have a question for us or want to interject an insight, please feel free to share it in the chat room. Okay, so I put together just some thoughts to get us started, a conversation around what are the problems. And obviously, I am not going to share anything that you guys don't already know or live with. So I was thinking about the lack, and that the problems can come from a lack. So lack of access, lack of easy navigation within the system. So thinking about what you went through, Cameron, when you were navigating systems, hospital, facility, hospice. That was not an easy navigation for you during COVID. A lack of understanding. We talked about this yesterday as it relates to what our experience is like and what we need and what we don't have. And then that lack of connections, which is related to just socializing, how hard it is before the pandemic to really have socializations, and then what it's like during. And then lack of respite. So adult day centers closed. Sharon, your husband's adult day center was closed for 16 months, 15 months.
Well, we didn't go. They were open sooner. They were closed for probably 8-9 months.
Okay, it's a significant amount of time to go without a break. And then I was thinking about lack of help. So Mark, you talked about how difficult it was to find help before the pandemic. And then I think about how it's gotten so much harder. So we're really in a direct care workforce shortage. And if you think about the vaccinated direct care workforce, that even limits the pool of availability. So those were the problems that I came up with. So what would you add?
A lack of access is definitely, but a lack of knowing where to go for information to help. So lack of understanding the networks that you can tap into.
Yeah, I was thinking that relates to navigation too. So we're working through a system and it's not easy to navigate because it's not easy to find what we need.
Right.
Yeah, and the only thing I can think of, and it relates to actually navigation and understanding, is evangelism for families with the specific conditions, right? So as a Duchenne parent, I know that we didn't have an easy time. There's definitely no guidebook, but there's certainly, we had to make our own way. And then we come find out that as we're making that journey, we could have did things this way, we could have did things this way, but it's always after the fact. And I think that because there was really, we kind of talked about it before the start of this, but when organizations are focused on research and they give a sliver for good faith humanity causes for people afflicted with what they're fighting or what they're researching, I think there's a miss there of being able to kind of cope with that. And I don't think there's enough of that. So it kind of blends into those two things.
Could we say lack of funding for direct support and services to help?
I think that fits. Even education as part of that.
Support services and education. Oops. Oh gosh, you know what I have? I have shrink to fit to help family caregivers. And you know what? We'll do both, and carries. But I think oftentimes we think about what's the help for the caree, but we really want to also think, well, what's the help for the family caregiver too? Yeah, I think that's important. And I do think that lack of funding became so apparent during the pandemic, that there really is there's no default. There's no safety net. It's us. And what else I was thinking around the lack of understanding, and I'm not sure I'm going to say this in the right way, so bear with me, but I think there's a lack of understanding of how much we do to keep our careys alive. I just don't think people got it. They saw it a little bit when you looked at what happened to residents of nursing homes without family involvement. I think then people started to think, oh my gosh, look what happens when you don't have a family member right there. Or when you had a family member navigating the hospital system without you. But I don't think that people get what a lifeline we are and what work we do to keep our careys alive. And
Well, Denise, to add to that, there's lack of training for family caregivers.
yes,
We are thrown into this role of caring for someone and providing services that trained nurses, doctors, and medical professionals provide, and we don't have any of that training. We're also thrown into the role of managing our loved ones' finances. And I mean, as a personal finance journalist, I mean, I've seen study after study showing that most, there's a large percentage of Americans who are financially illiterate. They can't manage their own finances, let alone someone else's, and now they have to do that. So there's a lack of training. I also feel like there's a lack of communication, starting with that kind of first point of access, which is with the doctors. You go to the doctor, your loved one is diagnosed, and then you might get some information about how to deal with this diagnosis and the condition, but the doctors, because they are that first point of access, they need to be walking families through everything, pointing them, okay, you need to go and meet with an attorney to discuss what sort of documents you need to have the legal right to make financial and healthcare decisions for your loved one. You need to talk to an attorney because maybe you need to set up a trust for your child who is going to need to be supported when you're no longer there. Here's information about, whatever assisted living facilities. Here's information about that. I mean, there's a lack of communication too.
and you know what that relates to? It's a lack of a billing code for those conversations to happen. So a doctor is only going to do what they can bill for. So there is now a provision within Medicare that they can have a conversation about end of life wishes and be reimbursed for it. But there's no easy referral system after diagnosis. It's really, well, this is a terrible day for you. Good luck. And I think we all remember diagnosis day because it is so profound. The other thing that I think is frustrating for me is that within our caregiving space, they still don't define the caregiving experience correctly. They focus too much on tasks. Now, we do tasks during caregiving, but we're also planning, strategizing, deciding, advocating, figuring it out on our own with training. So if you just talk about tasks, people don't get the emotional impact of the experience. And caregiving is an emotional experience. And if you were to ask family caregivers of all diseases, what's the one thing they all have in common? It's that they worry. That's the common thread during a caregiving experience. But it's so focused on tasks that a lot of times the information that's out there is about providing tasks. I can do the tasks. I can go grocery shopping for my mom, but it's how I feel because my mom is no longer able to go grocery shopping. That's what makes it hard. It's the emotions.
When you're talking about the diagnosis, we say in the FTD community, it's called diagnose and adios.
Yeah, that's exactly what it is. Good luck. Here's a pamphlet.
And there are no treatments, so it's you can't say, here, I'm going to write you a prescription. It's not cut and dried like that. So it's diagnose and adios, and you better find your own support. And being an advocate, here at Emory, I did a flyer that goes out to everybody that's diagnosed with FTD and what you need to do. Here's step one, here's step two. But sometimes it gets out, sometimes it doesn't. Even that, you could do it for them, and sometimes they don't do it. So I don't know where that ends up, but yeah, they diagnose and adios.
Okay, do you think we got the problems?
I think that's a really good list.
Okay, so here's what I think. If we were to bottom line this, is that caregiving is a painful situation. It's painful for our carees, it's painful for us, but it's also painful for direct care workers. And we don't really provide support for them, which is why I think it's one of the reasons why they haven't returned to their workforce. If you think about a home, oh, go ahead. I'm sorry, go ahead.
That and their salary.
Yes,
They-
that's part of the pain.
live above
Yes,
wage.
yes, that's part of the pain. That's part of the pain. And I also think you're caring for people who are dying. So your client dies on a Tuesday and you're reassigned to another case on a Wednesday. So think about all that loss over a period of time without any support. It's about, we need to slot you in. You become this transaction, this object, and there is no support around you. And then think about, you're not well paid. I mean, there's no way to be it. It's not an attractive job for so many reasons. And I think bottom line, if I were to describe it, it's because it's painful. So I think part of the other problem too is when you talk about the direct care workforce, I don't see anyone talking about the pain they experience because of the losses they experience. It's all about their pay and lack of benefits, but that's part of the pain. So I think we also really need to think about how are we communicating about these issues in a way that really speaks to what's the problem? And I think what we're looking to do is solve pain. But I want to hear what you guys think about that, because if I'm off base, let me know.
Oh, I think you're right on target. But there's certainly not, there's no simple solution here. And I was thinking especially about the direct care workers, because my mother was in a memory care facility for so long. And it was primarily women who were there working as aides in the facility. I mean, they were wonderful. They were so caring. I know it's not a high wage job, but the issue you run into is that the cost of long-term care is so expensive. And if we were to raise those salaries, it makes it even less affordable for people like me who couldn't do it on my own because I had 3 children of my own I had to care for. And so just we get into this vicious cycle. I mean, the same, like I was just listening to NPR this morning and they were talking about caregiving centers for children and how they're in the same situation where they can't, they want to pay their workers more to help their workers, provide their workers with a living wage, to make the job more appealing. But then if they raise the wages for the workers, then the people who are relying on those services, it's harder for them to pay. And so, it's across the board with caregiving. It's so tricky because it's expensive. If we pay the workers who deserve to be paid more, then the people who are using the service have to pay more, and then fewer people can afford it. And then we rely more on family caregivers who aren't necessarily equipped and able to do the care. And it's just, it is painful, but finding a solution to that, to easing that pain, it's not easy at all.
Well, like with memory care centers, these are private, they have stockholders that they need to pay before they pay the person that wipes the butt. And that's basically the bottom line. It's all about the money. And, you can't get past that because they're all private industry. They can charge whatever they please, pay whatever they please, as long as they can get people to do the work for it. So it's part of the problem is that there's oversight, but it's so loose, really, as far as costs and so forth. And I always tell people when they're looking for a facility, don't look at the crystal chandeliers. They don't take care of your person. It's the people that take care of your person. And a lot of these places have gotten into this luxury setting. They think that's what will attract people, are these luxuries that they give you. And that's not what matters. What matters is the care. I don't care if you give me a 75-year-old building that has linoleum from the 50s. If you're giving my person good care, I'm going there.
I mean, that's a big thing, right? It's the profit model that needs to be relooked at, right? Somebody, and it's not the workers that are getting their pockets padded in it, right? And maybe the business model and the cost model and the profit model are legit. I don't know. But what I do know is we've seen now Medicaid and Medicare mandates for vaccination recently, right? And coming down from executive offices, legislative offices, that can have a direct impact on benefit of quality of life for direct care workers, right? A mandate as easy as you lose a client, you get a couple days off to at least decompress, right? Things like that. So, I mean, I don't think it's one solution. I do think it's a series of solutions, but we got to understand all the pain points. Because again, it's multifaceted. So one solution is not going to cure this, but it definitely needs to be drawn out for sure.
And the education of the direct care workers is really lacking a lot. They don't, they get people that work in memory care put in less hours of education than a nail tech. They don't have, in a lot of states, they aren't licensed. In fact, most states, they are not licensed. So it's an education problem as well.
So I have been reading articles, so I won't work all the time, around how we work too much and that we would do much better with a 4-day work week. And there actually was a facility, a long-term care facility, that decreased hours. So a CNA, a certified nursing assistant, worked 32 hours, was paid for 40. And guess what happened?
It closed?
No, it worked out great.
I thought you were going to tell us bad news.
I should have said, guess what the good news is? Okay. I know, we're all waiting for the bad news, but they had less turnover. They had better patient care. And I think it speaks to what that day is like. It is just a bear for 8 hours to be on call all the time. It's too much for one person.
And they have too many people to take care of.
Yes, right.
So as far as the facility is concerned, if they can have one person take care of 10 people instead of 5 people, that's money in the bank, boys. So why not, right? Until the people burn out and then they're gone. So it's a multifaceted thing, and they don't even like to I know because I'm on the Georgia related dementia plan here. So I know quite a bit about nursing homes and memory cares, and it's never going to change until there is some regulation of that same thing as what does the CEO make and what does your lowest paid person make? If that gap is huge in memory care, you can certainly understand why they can't get workers. So, it's
So
I
here,
don't know how they're going to change it unless you make it, hopefully this new plan that they're coming out with, or the second part of it that's going to supposedly give help to people, see what that does. But when you don't have the education for the people that are caring for people, bad outcomes happen. It tell you some stories that curl your hair about bad outcomes, and because the person does not have any training. I mean, when a NAICS tech gets more training than the person hands-on in a nursing home or memory care, something's very, very wrong with the system.
Well, even to Cameron's point, of no training, right? I had to figure it out myself through my experience. We're required to train the people that come in, right? When we used to have people come in, and I'm not the right person to train anybody, right? Maybe the fact that I've done it, but that's about the extent of it. And I think, we have direct care workers here, and I think that even it just applies to caregivers, family caregivers as well. I don't know about the 32-hour work week for a family caregiver. I think that might be a stretch, knowing what we all do and have to do. But definitely, when we talk about the education support and the opportunities of growth within that area, even as a family caregiver, I think it's crucial on both ends of that role.
and I was thinking the 32-hour work week is for every employee. So every employed individual, and that gives you more flexibility than as a family caregiver to schedule appointments and to be available. Something that Sharon was talking about. So here in Illinois, any facility is licensed through our Department of Health, and they do have annual surveys. And you can also call and complain if you are in a facility that's not receiving Medicare, Medicaid benefits. It's not reimbursed. It's all private pay. You still have a license through the state. You still can call and complain and request a survey, and they'll go out and do a survey before the annual survey. And I think what's going to happen, because in addition, if you are licensed in the state of Illinois, you have to have certain number of certified nursing assistants per patient, per resident. And you're always looking at staffing levels. And with the mandated vaccine, we know that it's going to decrease staffing levels. So you're going to have smaller facilities, bottom line, because you're just not going to have the staff. So I just read an article earlier today that talked about how facilities have dropped their census, and census is the number of residents that you have in a facility, because they don't have the staff. So that's a direct impact on profit, but that's what's going to happen. And the other thing that I think is going to happen, that I think is a good thing, is they're going to look at private rooms. And I think as consumers, if we're looking at facilities, we're going to start demanding private rooms for everyone. One of the ways to stop an infection in a facility is if everybody's in a private room. So I think we are much more aware of infection and infection control and infection prevention than we might have been 2 years ago.
I do think, though, back to what Mark had said, it's going to take mandates, and it is, what you were just pointing out, Denise, Illinois has its own set of rules. Georgia has its own set of rules. Kentucky, where I am, has its own set of rules. There's a lot of variation from state to state, and you might be in a state where they have stricter rules, and your parent, your loved one, is going to get better care because there have to be more caregivers. There have to be, in the facility, they have to have more training. I'm feeling really lucky, like right now. I feel like my mom was in a really good facility where there were ample workers, ample aides there on staff, during all of their shifts. The ratio was really good. I do feel like they got really good training. I do feel like that they were trained well to when the pandemic hit, and they were wearing the proper gear. But I feel like it's going to take more than just state regulations. There needs to be perhaps federal regulations that, you know, like at least a bare minimum, you know, and there might, and I'll be honest, you know, I don't know. There probably are some already, but I don't know the extent of them, but there probably certainly needs to be more, especially when it comes to the training component. I did notice a very big discrepancy between the the training that was done in the facilities my mom was in versus the agencies that provided workers who would come into your house. I feel like those people were not getting as much training, especially during the pandemic. So when I brought my mother into my house after she was diagnosed with COVID, I reached out to one of those agencies that was actually providing workers for COVID positive patients. And it was a group that I had used before when my mother was living with me and I needed help keeping an eye on her while I was working. And gosh, I was shocked. Like, I was shocked that they sent this woman in with, it was not, I had an N95 mask that hospice had provided me, but this was one of those, it's like a KN95 mask, not the really high quality mask. So one mask, she didn't have gloves. I gave her gloves and they gave her this gown, but it wasn't like a plastic one. And I feel like they had not prepared her adequately to have to help someone with COVID, even though this agency was allowing their workers to go into homes with COVID. And she was scheduled for a shift right after an overnight shift with my mom. And I'm like, this woman needs to go home. She needs to shower. She needs to change her clothes. I let her leave early because I felt so bad about the situation. I'm like, well, I'm not bringing, you know, anyone else back in. This is more stressful for me than it is a help. But I was appalled. I was absolutely appalled. I'm like, they sent this woman into a very tricky situation, and I didn't feel like she had the training, the proper equipment, and I was absolutely mortified.
We've
Karen?
gone through that. Oh, sorry.
I just wondered, what was the hourly rate you were paying the agency, if you remember?
Probably $25 an hour.
Okay, and there probably was an upcharge because of your mom's COVID diagnosis.
I'm not entirely sure because I don't recall them, you know, granted, a lot of things were a blur from that week, but I don't feel like they said, oh, we're going to charge you more because of COVID. I don't think they did. It might have been a little bit more because it was an overnight situation.
Okay,
But
okay. I'm sorry, Mark, go ahead.
I was just going to say, even pre-COVID, we've had that same experience where we've had people come in and they're just not trained. They just don't have the materials. We provide gloves, we provide, you know, everything essentially. And, you know, you want to talk with us about what we were paying as well for care. And then, you know, workers talk and, you know, basically, you know, the half of that rate goes directly to the company and the worker maybe gets half or less, right? So yeah, it's just not a good situation at all. And it's a lot more common pre-COVID. And I can just imagine if that was the attitude prior to pandemic, you know, it bled right in, like the experience that you went through. So I can definitely, it doesn't surprise me, unfortunately.
Sharon, I think you wanted to add something.
Well, back to the closet, like Illinois has, they all have that. They all have oversight like that. But you still have a private corporation. These are not state places. So they don't have the inspectors to go, and it just oftentimes nothing happens. You know, we've had people here in Georgia that were literally killed. There was no two ways about it, and there were complaints. You know, they had a list of complaints, but how many people look for what complaints are registered against that facility when they're in dire need of putting somebody somewhere?
Right.
That's the other thing that people don't realize. You know, and they can talk a good game. I mean, these marketing people are pretty good at what they do, and they can talk a good game. And once you get in there, it could be a different story. So the oversight of workers that work with people with disabilities of any kind just is not there. I think the only state that really requires definite licensing and continuing education is now Massachusetts. But other than that, you fucking win. And like Mark said, you pay the agency $25 an hour. If that worker gets $10 to $12 an hour, they're doing well.
I think it also speaks to the trust of the system. So for instance, Cameron, you talk about hiring an agency that said, yes, we can care for your mom. And then they sent someone who clearly could not, who was not equipped. And then you start to think, I can't trust that there's someone who can care for my mom. And it's the same with what you're talking about, Sharon, where you think, okay, this facility looks beautiful. They're giving me this great brochure and they're telling me that my mom is going to have really great meals and it's going to be just this smooth transition. And then it's not that. And then you think, I can't trust them. And that's part of our pain, is that we wonder, who do we trust? Mark, I see you nodding your head. What are you thinking?
I think you hit it right on the head. I think when we have to administer care directly from afar, whatever, the minute that the people who are relying on lose trust, and I'm going through that with the doctor experience that I shared yesterday, I think, it's a lot more work. It's added pressure on top of everything else. And I think with the pandemic, it's like adding salt to a meal. It enhances the flavor quite a bit. I think salt was added onto these situations and we're really seeing them for what they are.
Wow.
And, trust is a big factor, definitely.
And once your trust is broken, I don't know that it ever comes back. I just went through, so my dad likes my parents' doctor. So that's the doctor we keep. But he's a pain in the butt. And so you can never trust that he's going to do anything. So I just went through having my mom go back on palliative care. And it's not just telling the doctor to order palliative care, which is what we did. I asked the nurse, I called her specifically and said, we want to order palliative care again for my mom. And then it was a visit to the doctor. And during that visit, we said, we want to order palliative care for my mom. And then it was 2 weeks later, and I was 2 weeks late doing this because my brother died in between. I mean, just think about this. It's like so stupid. I had to call and say to the nurse, has anyone ordered palliative care for my mom? And then I had to follow up with palliative care today and say, did you get an order? And the nice person called me back and said, well, we got a note, but it's not an order. So I just needed to check with my manager to make sure that it's good enough for what we need. She said, you're good. So then we scheduled palliative care for my mom. But who wants to go through that just anyway? And who wants to go through that when you're also trying to figure out, how do I help my sister-in-law get this service organized for my brother? Because we're trying to, honor his life. It's just so frustrating. And you just, once that happens, okay, I'm going to double check with everybody. I am not just going to take someone's word for, yes, we will do it. Mm-hmm. And think about how much time it takes to always follow up, which goes back to my frustration around the definition of caregiving, which is around tasks. I mean, if only, if only it was about just helping my mom with grocery shopping, if only. It is thinking ahead. It is thinking about who's going to do what and how are they going to do it, and then following up to make sure that they do it.
Wouldn't it be nice if there was like a concierge service, like even for people who are willing to pay extra for it at hospitals or whatever, that can help people who have, family members with special needs, and they can be the one on the call making sure, like the doctor's office, they give you concierge searches. Okay, you asked for this, we're going to follow through and make sure that it's done. We're going to keep making sure the doctor puts in that order for palliative care for your mom. When my mother had to go to the hospital for a biopsy in the pandemic, and then I was told by one person, she's going to have to come here. This was in Nashville. I'm in Kentucky. She's going to have to come here and get a COVID test. I'm like, well, I can't do that. If I take her out of her facility, she has to quarantine. And then the facility was trying to get someone to come in and do the test. And they couldn't get someone to do the test. And I spent hours and hours on the phone talking to the hospital, my mom's facility, the group that they partner with, to come in and provide care. And then finally I called back to the hospital and I talked to someone else. Like, oh no, we're making exceptions for people like your mom who have Alzheimer's. She can get her COVID test here. And I was like, okay, thank you. This is really wonderful. But why did I have to go through this back and forth? I mean, yes, I would have paid extra. And I know not everyone can afford to do that. Heck, maybe Medicare can chip in and cover that concierge service if it's related to medical care. Medicare will pay for hospice, which is a wonderful service, and pay for concierge care for people who have terminal illnesses so that they can lift some of that burden off family members and coordinate all that stuff that you spend hours doing, and it takes away from your time that you need for caregiving.
Yes.
But that's palliative care. A palliative care team should be doing that.
Well, you know what? So for us, for palliative care, it's just a visit from the nurse practitioner every 6 weeks. I mean, that's it. That's
Yeah.
the palliative care program that we have.
And my mom wasn't in hospice yet. She was not in hospice yet.
Well, palliative care is different than hospice. Two different things. All hospice is palliative, not all palliative is hospice. So palliative care can be given to anyone with any serious illness from diagnosis.
So actually, so it took me, I'm telling you, I fought for my parents to get palliative care. And they actually discontinued palliative care for my parents in May. And I had to say, okay, my mom had a heart attack. We need to put her back on palliative care. I wish I could say that it was so easy, but it has not been easy for me to get my parents on palliative care.
There's multiple problems there. One of the problems is that the physician mistakes palliative for hospice. A lot of times you'll hear they're not ready. And a lot of the places that do palliative also do hospice, and they will say, oh, well, we're going to drop you from palliative. No, you can't drop somebody from palliative. If they still have the serious illness, they still have the serious illness. It doesn't go away. So there's, by requirement, they're supposed to have a doctor, a nurse, and a social worker at the least. You should have a social worker who is the person that coordinates. And that's what they are supposed to have. But when people don't know that's what they're supposed to have, then they don't know to say, where's my social worker?
I mean, I don't know how many times my wife and I have had the conversation. Do we get a personal assistant or somebody to provide direct cares? We've had that conversation.
Yes, there you go. Right.
And, we've come close to pulling. I mean, I think the only thing that stopped us from getting a personal assistant is the complexity and the nature of the information that has to be dealt with, right? I really got to trust somebody to be able to do the right thing without oversight. And that's a little difficult in what we do. But yeah, I would definitely, I think there are times I need a personal assistant more than I need somebody providing direct care.
So I just want to let you know that we actually have a training program that trains life coaches to help with family caregivers. So they have help with stress management, decisions, strategies, planning. And then we have another level, which is a specialist, which is a family caregiver's personal assistant.
Perfect.
And they are all, so the specialist is a family caregiver. And typically if they've been in a caregiving experience for long enough not to be so stressed out, they have some strategies in place to help with the stress, but they understand what the stressors are. They understand what it's like to try to figure out scheduling and follow up and all that. So I think about family caregivers really as small business owners. I'm a small business owner. I have a coach. I have a virtual assistant. And that's what family caregivers need, a coach and a personal assistant. So I have a personal assistant through my business. I use her 10 hours a month. That's oh, but it's 10 hours a month that is like so amazing. And after my brother died, I just started telling her, here's what to do, here's what to do. And she picked up the slack for me, so I didn't have to worry about that. And I think about that specialist role that we have training for is something very similar, where you learn the nuances so you can step in and help out when needed. But I agree with, oh, go ahead, Mark, go ahead.
I was going to say, even everything that we do, right, that we pass off. I know somebody who was taking care of their mother. It happened to be on, I think, social media. And, hey, how do I explain this gap? Right? Well, here's how you explain that gap. Look at all the stuff you were doing and put it down. And I actually put caregiver on my LinkedIn profile, just as an example. Right. And hopefully that helped that person. I don't know. But when you take a look at all the things that we have to do, I mean, it just justifies that training. It justifies that need so much when you start breaking down your tasks to that individual thing. So, I mean, it's pretty important for sure.
One of the other things is we started a training program for family caregivers, and it's a certified family care manager, because that's the term I think about. The family caregiver is really a family care manager. And it's a it's 6 hours of live training. And there's a certification, because I think if you're looking at a hole in your resume, if you can put that you were a certified family care manager and you managed a budget of, the budget that you could manage could be hundreds of thousands of dollars every year, depending on where your caree is living, and that you made decisions around care and you oversaw staffing. I mean, that's why you are running a small business. You are running an enterprise when you are in a caregiving situation. And you're right, Mark. I think if we really looked at what we did and the budget and the decisions, it's amazing that we're able to do this. I mean, where do we find the time? I mean, no wonder we're exhausted.
Mm-hmm. Helps with evangelism too, to help some of these problems that we've come across, right? So people don't have that visibility. Being able to put that out there in that kind of detail, I think it paints the picture just a little bit better as well.
Yeah, because we kind of take it for granted. And I will also say that the system delegates it to us in a way that doesn't seem like that big of a deal. Oh, I mean, if you've ever received directions at discharge on wound care, it sounds like a no-brainer, right? But then you get home and you're like, oh my God, okay. I didn't know it was going to look like this. And I didn't know it was going to feel like this, but I'm going to do it anyway. And so that delegation from the system to us makes it seem like, oh, it's a no-brainer. Why am I squeamish about this? Or why is this causing me sleepless nights? It's because you have a life that you are caring for, and you are now feeling this responsibility to keep this person alive. It's not a no-brainer, right? Yeah. Okay, so we have 5 minutes. We have 5 minutes left. So what solutions should I add, do you think?
I think another solution would be to provide more education to people who work in the healthcare system about, and this is specific to Alzheimer's and dementia. I mean, obviously you're in a hospital, you're in a doctor's office, you're in a medical facility, and you know what it's like to deal with people who have illnesses. But I think there needs to be special training for dealing with people with Alzheimer's. I can't tell you how disappointed I was whenever I had to take my mother to the doctor's office, to an emergency room, to the hospital when she was in the late stage of Alzheimer's, and she had no idea what was going on, and she became combative because she felt she was threatened. And I hated watching the way that they would respond to her, like she was a crazy person. She wasn't a crazy person. She had Alzheimer's disease and she didn't know what was going on. And the absolute worst is when I had taken her to the hospital. She had this biopsy done, and it was during the pandemic and they didn't have their valet parking. So I had to go and get the car. A nurse came down with her in a wheelchair and was waiting, But then my mother, of course, is getting agitated and worried, and there's a security guard there, like oh my gosh, this is 77-year-old woman, we got to keep her under control here. So the security guard, I pull up, and the security guard is like manhandling my mom because she's irritated, and they're trying to get her out of the wheelchair and into my car, and I get out and I'm like, she has Alzheimer's disease, can you just back off? There needs to be more training across the board for people who are interacting with people to understand that someone who is in the late stage of cognitive decline, you have to respond to them in a different way. You don't sick the security guards on them. You don't, whatever. You don't force them to get their blood pressure taken if it's going to make them agitated and make them lash out. I just that was so frustrating for me, is watching how poorly those in the healthcare industry responded to my mom. I mean, people at her facility knew how to respond to her because they were taking care of people with memory issues day in and day out. But the healthcare system, for goodness sakes, they didn't know how to deal with my mother and her Alzheimer's, which I'm sure they get plenty of people with Alzheimer's in their offices, in their facilities, and that was devastating to me.
It's just we had talked a little bit about this yesterday. It's just the lack of seeing people as human beings. That once there's a disease or a diagnosis or a disability, somehow I don't know, I just don't know where we moved away from humanity. And to be able to be compassionate and just take a few moments to be compassionate. I mean, what 77-year-old woman needs a security guard? I mean, yeah. So Hal is sharing in the chat room that his mom didn't want to do physical therapy. So physical therapy wouldn't force her. So she needed to do it to get back to her assisted living facility. Right. So she's in the hospital. They're trying to get her back to her facility, but the facility is saying, here are the requirements to get her back. But the hospital isn't working with her because they think she is not compliant. Right. Oh my gosh. Yeah. Right. Yeah. I think it's this idea that the system wants us all to mold within the system and make it as easy as possible within the system. Whereas the system can't mold to what's going on.
I also think there's a simple solution too for that that first point of contact and that diagnosis, so that maybe the doctor can't bill the conversation, but there can be an effort, whether it's, I don't know, individuals like us, or it's associations that advocate for people with diseases and conditions. They provide a pamphlet to the doctor's office to hand out to people. Your mom was just diagnosed with Alzheimer's. Here are support services. Here are caregiver support groups. Here are some steps that you should take. Meet with an attorney, consider meeting with a financial professional, reach out to whatever, your local Medicaid office to see if your mom can qualify for long-term care services through Medicaid. I mean, it's a brochure. That's it. They don't even have to say anything. They just hand it to you. Here you go. Here's the information. But I think that would be so helpful.
Yeah, we have a one-page flyer that we hope to have doctors' offices give out that has just really simple suggestions on here, just give this flyer to the family. That's all you have to do. You don't have to explain it or describe the services, just give the flyer. Something easy. Yeah, yeah. I guess anyway, I'm not gonna say what I'm thinking. Okay, so let's close up with final thoughts. So Sharon, what would be final thoughts you'd like to share?
If they don't make universal requirements for things, it's never going to change. There has to be a top level down of requirements for people that work with people that are ill for any reason, whether it be home health aides or a facility, or they have to make universal requirements for people to know, like Cameron said, that forget about it with dementia. I mean, like I said, they get those workers get less education than a nail tech. And it has to be universal. It can't be this piecemeal, 50 different states doing 50 different things and nobody's getting what they need. It has to come from the top.
And that's such a good point too, because depending on where you live, you could be interacting with 3 different systems. So I'm in Chicago, which is close to Indiana and Wisconsin. And what happens in Illinois isn't what happens in Indiana, is not what happens in Wisconsin. So you have to know 3 different systems, and that's a nightmare. And the other thing too, gosh, you're making me think this through now, Sharon. If you qualify for Medicaid benefits in the state you live in,
Right.
but what if you move?
Yeah, there are different requirements. Every
Yes.
state has different
Right.
requirements.
Yep. Yeah. So
We can't move out of Georgia because in
cannot.
Georgia,
you
well, I
can't.
can't because in Georgia, they do not consider your 401k an asset unless you're taking out of it. That money is considered an asset, but your whole 401k is not. I go to North Carolina, exactly the opposite. Every single thing I have is considered for Medicaid. So things like this have to be universal because people are just not, and forget about rural. I mean, rural people are they're just abandoned pretty much.
I know.
They don't
I know.
they don't have anything. And yeah, it's very, until there's something universal, I hate to say universal health care, but if we don't do something, this whole thing is going to get worse and worse and worse. Baby boomers are getting older and older. There's so many that the whole system is going to go down. I mean, it's not feasible to continue the way it is. It's just not feasible.
You know what else? And licensing. So we did get
Yeah.
some help during the pandemic for doctors to be able to, there were no borders anymore between your licensing for a state. If you were a doctor, you could prescribe medications and see patients in other states. And I think that goes along with it as well, that there's one license for the state of Illinois, or for the United States, not just one license for the state. Okay. I like that so much. I like that so much. It makes everything so much easier. Okay.
It makes it easier on the people that have to use the services.
Yes, absolutely.
It
You
might
don't
make
have,
it more difficult and paperwork up the line, but it certainly is better for people that are taking on the burden of not having their person in state care. So, we're saving them a lot of bucks.
yep. Okay, Mark, what would you add?
I mean, it's a big ditto right there. I mean, that would be a game changer. I mean, on top of that, what we can do, I think, is more evangelism. It's really hard. It's not like we don't have other things going on to be able to get in front of a group and talk about these things. But I think it's necessary. I think everyone needs to hear the stories that we've heard over the last couple of days and more. I would love it if, our legislatures came and wiped Lucas's butt in the morning, like, we have to. I mean,
Right.
do the routines, see what it's really like. I have yet for anybody to have me explain in detail what that life is like, or my wife, except for other caregivers, right? So I think that's really a big part of it. It's evangelizing, seeking to have other people understand. And I think that helps kind of close that gap of that disillusionment and fear.
Yeah,
Because
okay.
people on the outside think that when we are in these quote unquote systems, we are being serviced. they don't understand that you're not. It's like, it's kind of like the COVID shot. Until it hits in your family and somebody dies, all of a sudden the COVID shot is something that you want to get. So until it happens to you, you just assume that, oh, well, obviously there are services for that. Yeah, no. A family with FTD spends $120,000 a year. Alzheimer's is $60,000 a year. Who can afford that?
Right. And we are looking at millions of family caregivers who are going to enter their future in poverty because of how much they spent during a caregiving experience. And there is no system in place to help. We don't have the budget for that, which is why we are in such a crisis. The crisis is happening right now, but the impact is going to happen in 5 years, 10 years. We are not ready, and we don't have any way to manage that. None. Okay, Cameron.
So I think some things that can be done to help family caregivers. I think for starters, there needs to be, like whatever, Society for Human, SHRM, Society for Human Resource Managers, the various groups out there, that work with employers, a big push among them to encourage employers to allow more flexible work schedules for family caregivers. Work from home, we've seen that it works. This past year has allowed employers across the country to see that their employees can be trusted to work from home. And you might not lose employees who would otherwise have to leave if they can simply work from home and just kind of check in on mom or dad or their child who needs care from time to time until those care needs get really great. Being able to use that flexible spending account, not just to pay for care for your children, but to pay for care for mom and dad whom you're caring for, to be able to tap that 401k without any early withdrawal penalties, without even paying taxes on that income if you have to use it to pay for long-term care. That would go a long way. It's like, oh, I've got all this money that's saved for retirement, but now I need it to pay for my care. Well, you're going to lose, 10, 15, 20% if you have to pay taxes on it. And if you have a disease that forces you to start taking that money before you're 59 and a half, you're going to pay 10% on top of that, maybe even allowing family caregivers. I mean, it's terrible. I don't think people should have to take from their own retirement account to pay for their parents' care because, like you said, they're going to end up in poverty. But if that's the only source, they shouldn't be penalized. They shouldn't be paying that early withdrawal penalty or taxes if they are paying for long-term care. I think there are a lot of things that can be done on that side. Tax credits. I mean, I know, in very limited situations, you might be able to claim your parent as a dependent, and get write-offs for that, but it's really hard to meet those thresholds. But, tax credits out there for caregivers to make it easier to offset some of the cost that they're bearing. I think a lot can be done on that side to make it a little bit easier for family caregivers to not go into poverty, or at least go less into poverty.
So there is some legislation. There's the the credit for caregiving. That's legislation. And there's also legislation that you are not penalized if you have to withdraw for your 401k to pay for, I think it might be to pay for long-term care insurance. Not exactly sure. I can't remember, but there's been a lot of legislation that has gone through. And I think we need to look at what's the trigger for conversations. So for instance, when an employee says, I need to take family medical leave, to me, that's also a conversation about caregiving. So then there's a referral to, for instance, a certified caregiving consultant to talk about what's going on that you need to take family medical leave. How can we use this time effectively so you can return to work? And it's a conversation before you tap into the 401k. What are you going to use the money for? Let's think this through and make sure you have used all other systems or resources so that this really is a good decision. I think there's a lot of triggers to good, effective conversations that don't happen. And that, if we had effective conversations because of triggers, I think we can see people using services more effectively and making good decisions and connecting to support in a way that doesn't happen right now. Okay, so we got 11. Last call for any that we want to add. Okay, so what I'll do is when we put up the archive of our 3-part series, I'll include a link to this PowerPoint so people can see what the solutions we came up with. And let's keep in touch, right? Let's continue to evangelize. I love that word, Mark. Thank you for that word. That's just what we want to do, right? Get out there and talk, right? This is what it's like. This is what I need. I'll just add one other thing. So I shared that story about going to get a massage and I couldn't get a vaccinated massage therapist. That location has now changed their policy. You can go in and ask for a vaccinated massage therapist. So if you evangelize, someone might listen and things might change. It can happen. It can happen. Okay, thanks so much to Sharon and Mark and Cameron. So appreciate you sharing your days and experiences with us, and so appreciate talking this out. It really was fabulous.
Thanks for having us.
Thanks.
Okay,
Thank
thanks
you.
everyone. Bye-bye.